This is a burning question always for clinicians like myself. How well am I actually managing a condition? How well do I manage celiac disease? How good is the clinic? And it probably should be a burning question for all of us, really, and that's, I think, why we're here to a large extent. At the moment, I think we don't really have the tools to know very well how well we manage this. I'll probably only know when my patients all up sticks and migrate off to Sheffield and decide that it's no longer safe to live in Cambridge if you have celiac disease. Or perhaps Dave and I will only find out when they all go to Finland. But we do desperately need to know the answers to these questions. We do have some statements of quality standards. These are from NICE. I won't read them out. You've already read them, I should imagine. But I would point out a couple of things about these. They are wonderfully light on detail and on evidence. That's because they are NICE-based, and NICE is very rigorous about supporting any statement that it makes with evidence. And they're also largely processes rather than outcomes. These are quality statements based on processes. We know we don't do very well. This is data from the States going back a few years now, cumulatively showing how many patients actually get follow-up celiac appointments after 5 years, trending towards 100% after 5 years. This is how many of them actually saw a dietitian over that period of time. And old data now, but we know that we're very under-resourced in the UK to provide this sort of service, and if this is a quality measure, then we are not in a good position where more than a quarter of our hospitals have very small amounts of dietitian time per head of population. But I think what we really need to look at is not necessarily the processes. I've shown you these quality statements based on process. Processes are informed by outcomes. What we're really interested in is the outcomes, and using those outcomes really to define the processes to get them, or refine the processes. Some of my colleagues in Cambridge and East Anglia in paediatric practice have looked at defining quality outcome measures in children, and they've looked at measures associated with diagnosis or with follow-up. Again, if you look down that list, these are all processes. This is a process audit, apart from one down here. TTG less than twice the upper limit of normal within 2 years, which is an outcome measure that they've generated to follow up. The evidence basis for that is unclear. So I think we have to start, really and appropriately for today, we have to start with the patient. What does the patient want as an outcome? Firstly, I would say they want to know, have I really got celiac disease? And secondly, they want to feel well, and those who are aware that celiac disease can have late complications, even if they're feeling well and carrying on eating gluten, they would want to stay well as well. What do these translate into? Really means I don't want to be on a strict gluten-free diet unless I really have to be. And I don't want to be on a strict gluten-free diet if it's not doing me any good. And I don't really want to follow a gluten-free diet if I then find that I'm going to end up with late complications of celiac disease anyway. What are our tools for diagnosis then? Well, we've got the tissue transglutaminase ELISA, which is standard in the UK, with the anti-endomysial antibody, the immunofluorescence test. We know that that's the same antigen as the TTG. And we have the biopsy, and I've put up a characteristically bad biopsy sample to look at there, which is cross-cut and could be interpreted in any number of different ways, depending on which way you look at it. Do our patients all have celiac disease? Well, this is one of my patients who, rather to my embarrassment, turned out not to when she wasn't getting better, and we re-biopsied and found her giardia. So she had a parasite instead. And then went back and looked at her index biopsies and found that she had it on those too. And of course, others have looked at this from Pavia. Gina Carrazza's group have looked at a number of patients referred to their service. And they found that out of 180 where they had reason to doubt the diagnosis on the basis of the tests that had been performed before, they were only able to confirm the diagnosis in 60 patients. So we've got this fabulous tool of the tissue transglutaminase antibody. We know that it's got a very good sensitivity and specificity. This is data from NICE, and this is purporting to show the sensitivity and specificity of the antibody. But these tests, these studies here were never designed to test the sensitivity or the specificity of this antibody. You can't do that in a sample of 40 patients, of which 10 times as many of them have got celiac disease as haven't. That's never going to give you any interesting information about it. This one here, from Dave's stable in Sheffield, was the only one which really set out to test this properly. And this is the data that we've come to rely on very significantly. This is it here. They showed a sensitivity of 91% and a specificity of 91%. What that means in their series was that if you had a positive tissue transglutaminase antibody, the likelihood of having celiac disease was 28.6%. It means that if you had a positive test for celiac disease, you are more than twice as likely not to have it as to have it. So this has really largely driven our practice in the UK, where we have a two-step process, where we have the tissue transglutaminase and the endomysial antibody using the Reverend Bayes and his famous theorem, which suggests that it depends on the prior probability of the condition as to what the true positive value of the outcome is. So in the series from Sheffield, there was a prior probability of 3.85% in these patients, which translated into a true positive of 28%. In some patients, we might be able to enrich that by perhaps selecting those with iron deficiency or irritable bowel type symptoms and get a higher value of this test. But then, if we use that as our prior probability and put it through another test, we can then, and it's the specificity here which matters more than the sensitivity, we can come up with really very good performances for our tests. The problem with Bayes' theorem is that these tests, the TTG and that, have to be independent, and I don't think we can truly say that they are independent tests in the setting. So when you look back at the Sheffield data, there was a 72% chance using this two-step testing of having a true positive from those results. So still quite a high likelihood of not having celiac disease even if you had those two tests. That's using this data. This is now from the latest NICE guidance, and that's using this data in adults. If you actually use a different data set, the predictive, the true meaning, the likelihood of having celiac disease with a positive test using the two-step algorithm here goes down to 53%. And we have cheaper ways of that sort of outcome. In the UK, we have a plethora. These are all the different kits for testing TTG antibodies in the UK. This is the one that's used by, well, so the 473 different labs, all of these different kits, all using the same antibodies and you do purportedly the same test. This is the one used in Sheffield. This is the one used by ourselves and others in a series of about 500 patients. Not the same series, not the same type of study as the Sheffield one, but we've got a 17% false positive rate compared to a very high false positive rate using this assay here. It suggests that these are actually different tests, even though they're the same test. It gets worse than that, actually, because we now know from pediatric practice that they're using, trying to avoid biopsies for diagnosis as much as possible and using an upper limit of normal of the test. And this is work again from Sheffield, Bill Egner, showing that using the upper limit of normal is very variable on different tests. These are different samples using different tests, some here with 3 times the upper limit of normal, some with 10 or 11. And it's even worse than that because this is just one standard deviation. The labs accept 2 standard deviations of variability. So you can double these lines, okay? So at least we've got the gold standard of the duodenal biopsy, haven't we? Well, this rather put the cat amongst the pigeons. These are the same biopsy samples, sectioned differently. This is the better orientated, showing villus atrophy. These could be passed as showing good villus architecture here. So we can't really even truly rely on that. And it probably gets even worse because we sometimes have tests where one is positive and one is negative. And how do we then interpret those? Is it a false positive? Is it a false negative biopsy, in which case we might be subjecting people to late long-term complications, such as this lady who presented with osteoporosis in my practice? Or if it's a false positive on the serology, then we're looking to be doing more biopsies, or we're going to be putting our local bakeries out of business. So relatively little data on what we call potential celiac disease. And of course, what I've just shown you about the unreliability of the antibody test is that this is only relevant to any particular center. It doesn't have any relevance to anybody else using different tests. But it shows that these probably aren't. These are patients who are destined to go on to become celiac in many cases. We've been looking at a cohort, a prior cohort from back to 2003, and shown that actually there is a significance in having that antibody, even if you got a negative biopsy. We're still following this group up thanks to a very generous support from Coeliac UK with a student project. But equally, we know that people with low levels of inflammation on the biopsy respond to a gluten-free diet as well. So is it truly a false negative biopsy if it doesn't have villus atrophy but does have degrees of enteropathy? So we're in a bit of a pickle, really, and we're at a stage where we're redefining celiac disease, I think, and what it is and how we understand it. And we're going to be hearing a lot about this later on today. We know that innate immune pathways are probably fundamental in initiating celiac disease and working alongside it. We know that if you have the right HLA, then adaptive processes, adaptive immune pathways kick in, and that's what we call celiac disease. And perhaps what we're talking about without the appropriate HLA is the non-celiac gluten sensitivity type patients. We do have a definition. It is vague enough to cover all potential possibilities here, but it may be that at some stage we might want to revisit this in the light of recent developments. Particularly when we have what I call the Marsh gap, which is where some people, and it seems to be down to physician discretion, would not diagnose celiac disease in patients who had subvillus atrophy grades on the biopsies. So have I really got celiac disease? For any particular patient, I'm not really sure any longer, to be honest, probably. But what I do know is that every centre should understand the performance of their tests, and that goes with standardising their biopsy profiles as well. And I'm beginning to wonder about this as well, actually, and whether we really do need to have an ongoing working party and consensus on that. Okay, so moving on. I want to feel well and stay well. Well, perhaps we should be routinely measuring the quality of life in our patients, and it's lovely to see the posters outside and a lot more interest in this area. And there's been a proliferation of scores that have been defined for celiac disease, and I really do apologise if I've left any particular ones off. I've seen another one outside which isn't on that list, and these have been driven as much by commercial developments in trying to test new therapeutic advances that we're going to be hearing about from Daniel later. But there are difficulties in looking at symptom scores because we have great difficulties in defining symptoms in celiac disease. It can be very broad and varied. It can be very low level or non-existent even. And if we're just going on symptoms, then we might still be laying our patients open to those later long-term complications just by defining them being symptomatically improved. We get the feeling well bit, but not the staying well bit, perhaps, if we do that. But if you follow a strict absolute gluten-free diet, then you will feel well and stay well. So perhaps we should routinely measure dietary adherence. I'm not a dietitian, but I do know how difficult this is. Daniel, again, has produced this CDAT, this adherence test, and clearly asking the patient whether they're eating gluten is quite important in knowing whether they are adherent. Some of these are actually personality rather than behavioural, and I'm not sure how much those could be changed and how we can alter the outcomes by necessarily applying this. Having said that, it works very well, especially compared to self-reported adherence, but still fairly low on the ROC score. But this is something we can now look back at. We've now got an outcome that we can measure, and we can now look back at the process, and we can say, is dietitian use associated with celiac disease outcome using different scoring systems, which is great, that's what we're after. No particular difference, unfortunately, with any of those three scoring systems, quality of life, symptom index, or the adherence test. So we've got a process that is part of our quality assurance process, if you like, and something that we're told that we should be adhering to. And actually, we haven't been able to prove yet a beneficial outcome as a result of it. In my patients, I think it's probably because of unknown contamination occurring, and Coeliac UK have been very active in my neck of the woods, making sure that restaurants are actually doing what they're saying they're doing when it comes to gluten-free food. So what about surrogate markers? Now, we all love the tissue transglutaminase antibody again. We've seen how variable it is in diagnosis even, but here we are in follow-up, and this is what we all like to see. TTG titer falling. Oh, and here the patient has just had a little blip. They've decided to test it and see if they really are celiac or not. And the tissue transglutaminase, they've been found out here, and the tissue transglutaminase antibodies gone down again. Interestingly, this was below the limit of 10 was the upper limit of normal on that assay we were using at the time. But what do you make of this one then? So this is a patient who was celiac and did the right thing with the tissue transglutaminase titer coming down. Weight went up nicely on the diet. The biopsy was a little bit less impressive. This is a composite score based loosely on the Marsh scoring system, grading system. Tissue transglutaminase titer goes up. So we rebiopsied. Entirely normal. Over follow-up over some years, the tissue transglutaminase titer stayed high, but the biopsy stayed entirely normal. This is quite characteristic for a number of patients, and I would say that there is no good evidence to support the use of serology in follow-up. We would say quite the opposite. From our series, we found that we only picked up less than half of those patients with ongoing villus atrophy when we looked at the raised tissue transglutaminase, and possibly even worse, about a quarter of patients who had normal biopsies actually had a raised tissue transglutaminase titer. Some of these we were actually inflicting iatrogenic harm on. Their symptoms all got better when we told them their biopsy was entirely normal and not to worry about the tissue transglutaminase being high. But when you look at what are the markers of patient satisfaction, we find that these don't reach significance, symptom severity and quality of life, but having antibody levels checked yearly, that's what the patients seem to want. Okay, that's because we tell them it's a good thing. But not only that, what it means is they're getting feedback. That's what they want. They're saying they want feedback on how well they're doing on their diet. And we need to have some feedback as well on how well we're doing as a service. When we look at celiac disease, we really do only have these two at the moment. Hopefully after today we'll learn of some more things we can measure. But the antibodies are probably less direct than the enteropathy. But we know that rebiopsying is not popular or pleasant, it's costly, and there are a number of drawbacks to it. It does provide a tangible outcome. It does provide reassurance to the patients. There is a direct relationship to the pathology. It is at least the least unreliable of all the tests we have, but we don't have it easily available, and we have to really select how often we do it. But it does, again, provide us with a solid outcome. We can then go back and alter our processes or adapt our processes as a result. And I'd like to show you how that's adapted the pathway in Cambridge. So our first version of this a few years ago, we had our standard 2 appointments in the first year. We biopsied at a year and did a DEXA scan in the majority at a year. We had a meeting with the doctor and the dietitian afterwards in the clinic to go through the results. And then we did the annual follow-up. We weren't quite sure why we were doing this in a large proportion of cases and what we were meant to do and what benefit it really had, but we were doing this. We found that a lot of our patients who had ongoing villus atrophy on that biopsy, we could identify gluten in their diet when it came down to this third clinic appointment. So we said, right, well, let's just bring that further up here then, and we'll put that in before the first biopsy so we can go through that. We also thought, well, perhaps we don't have to follow up everybody in quite the same way, and we started off by suggesting that the GPs might like to follow up patients at a year. We're now on a third iteration of this, and this looks like this. We've now got the 3 clinics in the first year. We have a group education session which takes place every month with patients and family, the people who do the shopping and the cooking in particular. And we then have a clinic just with the doctor to check the diagnosis, given how often we're seeing the diagnosis has been wrongly made. We then have 2 clinics with the dietitian before the biopsy, and then we can discharge, which we do in those cases where we have got a good histological outcome, or follow up selected groups, adolescents, for instance, or those with ongoing symptoms, or villus atrophy on biopsy, for instance. This is not published, and we are currently validating this. What I've shown you about the reliability of the biopsies, we're now going back and looking at this with an independent histopathologist just to confirm this. But we've been looking at our outcome, the biopsy outcome, and the ongoing villus atrophy at a year after initiation of the gluten-free diet has fallen from around 40% to around 13% following the changes in our pathway we've made as a result of monitoring this. Those with an entirely normal biopsy, reported as an entirely normal biopsy, have now gone up to around 68% of our patients at 1 year after this, having made those changes to the pathways result. As I say, we're going back and validating that, and again, it's due to the generosity of Coeliac UK that we are able to put a student onto this and work through this and actually validate this outcome. So, as I say, this is preliminary. So I like to see celiac follow-up and management a bit like this. Forgive me, because I do spend most of my life in the hospital, so I tend to think of it as planet Earth. And I think that it's all about getting the patient into a stable Earth orbit, if you like, into primary care, away from secondary care. So we start off with our launch, which is the education session, going through what celiac disease is, what happens if you don't stick to a gluten-free diet, and about symptoms and management and so on, and then how to go about the gluten-free diet. And we have the dietitian giving a quiz and going through that with the patients and their relatives. We have the shoppers and the cookers there as well, not just the patients. We then have 2 booster rockets, if you like, the 2-month appointment and the 6-month appointment to get them up into orbit. We then check that they're actually high enough in orbit to be able to stay in stable Earth orbit and not fall back down to Earth. And then we're happy that they can stay in primary care. What we don't know is what happens later on to those patients, because we're worried that they might drift off into space or at some stage fall back to Earth. And this is ongoing work. That's probably the value of the annual appointment, and it probably is only to remind them they have celiac disease, and we think there are probably better ways of doing that, like having a regional annual food fair, GP records and that sort of thing, where we can invite people to them and have a bit of a celiac jamboree, if you like, with ongoing talks and topics of discussion, and workshops perhaps as well. So that's what we'd like to set up, but we're currently looking at that at the moment to see that they are still staying there. So in summary then, the quality in celiac care is really where we now need to focus many of our attentions, I fear. Processes are not the same as quality outcomes. Outcomes inform those processes. We still really need to define our quality outcomes in diagnosis and follow-up. And only then, when we have done that, will we be able to improve our own services, derive process standards, so that perhaps we then don't have to biopsy everybody, and we will know that doing certain things along the way does lead to a better outcome in terms of biopsy outcomes. We'll be able to compare our services with others. And we'll be able to standardise approaches based on the best outcomes. I showed you that list of antibody tests across the UK. If I knew that my test was performing really badly compared to other hospitals because we were routinely comparing our data and our outcomes, then it might well serve to standardise that, and I think that list would get a lot shorter. And I think Coeliac UK is extremely well placed between professionals and patients to be able to lead on this quality initiative. Thank you.
That was fantastic. I think we'll take one question if there's anybody with a burning question. Paul, there's a microphone there.
I found that very interesting. I'd be interested in your comments, because they're outside. We're being, and David got a poster on this, that you do a Symptomax test, or prick test on your patient when you do an endoscopy, and the test is if it's negative, you don't do a biopsy. But what your data there shows quite clearly is a general agreement that 9 to 10% of patients with celiac disease have negative serology. So possibly we're potentially going to be missing these patients. What are your views on that?
Yes, indeed. I mean, if we're entirely dependent on a serology test, then that's we've got to look at the performance of that test before we avoid doing biopsies on patients, and we've got to know that it's going to be performing at an adequate level, really.
Jeremy, thank you very much.